Pediatrics spending time to get this space correct. The other important thing I want to present before we get into the mission-based is our Preventable Harm Index. So what is preventable harm? So preventable harm are things that we believe should not happen. If we do our job right, these things should not be happening to children in a hospital. This is our 2013 data. These are the subcategories: catheter-associated urinary tract infection, catheter-associated bloodstream infection, surgical site, ventilator-acquired pneumonias, adverse drug events, non-ICU cardiac arrest, serious falls. So in 2013, and this is hard to read, but the maroon is zeros. So usually you see a slide that's all red and you go, oh my God, this is really, really bad. The more maroon on this, the better. In 2013, we had 121 events, or an average of a little over 10 a month. 2014, we had 92 events. We had dropped this by almost a third. This is an incredible amount of effort. And really, I want to give credit to the people that did this work. And number one, it's all of you. It's people that are actually at the bedside caring for these patients. But it's Abe Jacob, Sam Gupta, just a host of individuals, especially our pediatric surgeons who really did a number working to bring their surgical site infections down, doing this work. This has not been released publicly yet, but we talk about it a little bit in here. A lot of this happened after we instituted the daily safety call. You can see our preventable harm index has dropped and generally stayed below this line. It's actually even a little bit better this year now. Because of the effect of this daily safety call, the Minnesota Hospital Association is awarding the University of Minnesota Masonic Children's Hospital their 2015 Safety Award. So it's a really nice feature that Abe Jacob basically single-handedly forced the creation of this safety call, and it's done an outstanding job for our kids here. So we do three things beyond have to learn and have talks, and they all kind of fall under these categories of education, research, and patient care, and we'll kind of hit all of those. The one thing I never can figure out here is what time it is. All right. So our education mission. So the goals and the vision were something we set up as a faculty about 2 years ago when we met. For education, it has been, about attracting and inspiring the best and brightest learners from around the world to interdisciplinary innovative research and clinical programs, and ensuring the readiness of the next generation of pediatric medicine. So what's been happening? EPAC, Education in Pediatrics Across the Continuum, launches June 1st of this year. We've talked about this a few times, but this is a very new program. It involves 4 universities from across the United States. And we'll hit on that a little bit later, but this is launching June 1st, and some of you will be impacted by this. Pediatric clerkships have done well at all 4 sites, including here and the Fairview Children's Clinic. Our electives are popular among the medical students. There will be new sub-internship rotations created in the PICU and NICU for 4th-year medical students. This is something that's moving out across the medical school now. And the AAMC has published core and trustable professional activities for medical students entering residency. What should the students actually know how to do before they show up that first day on the floor? So these are out now and are probably going to affect the way we teach in our residency program, in our medical school programs. We have very active GME programs. Emily Borman-Shope, who is on spring break with her kids now, leads this for the residency, but a number of associate program directors at Children's, at Hennepin, as well as a number of people here as well. Patty Hubday, Mike Pitt, Tom George, Maren Olson, and then Sonia and Angela at the Children's Hospitals. We have 69 residents here on site now, including 4 chief residents. This is where our residents have come from over the last several years. The bulk of our residents, not the majority, but a substantial minority of our residents come from our own program. They stay in Minnesota. we get a good number of residents from Wisconsin and Iowa, Illinois, and then it tends to taper off towards the coast. It's fascinating that we have nobody from California. You would think a state that big would have produced at least one person who wanted to come here, but nobody. Our residency graduation data for this year, 11 of our graduating residents entered pediatric practice. 8 of them stayed in Minnesota. 13 of our graduating residents elected for continued training in fellowships, 6 of those staying in fellowships here at the University of Minnesota. We have fellowships in a number of things, adolescent medicine, developmental behavioral, ID, GI, rheumatology. We also have some non-accredited fellowships that really are made available to learners looking to seek advanced training, in particular our bone marrow transplant and advanced neonatal perinatal fellowships. We also have a very strong fellowship in academic general pediatrics. Educational innovations. This past year, the cognitive bias curriculum. Again, Andy Olson presented this last week. This is sponsored by AAMC, has been presented. Really talking about how we look at our patients. All of us live in an environment that almost encourages us to have cognitive biases, and how can we separate ourselves from those to actually get to the right answers. Quality improvement curriculum for our second-year residents has been very successful. Our PL2s now are actually developing projects early in that year. They're working on them through that year and into their third year, at which point they're going to be able to present them. And some of them are going to be presenting those at PAS just later this month, I guess. The Teach for Quality initiative has involved several of our faculty participating in AAMC training, and then a game-based learning innovation that has been presented at the level of the American Pediatric Program Directors. Certainly a lot happening there. And then EPAC. So EPAC is Education in Pediatrics Across the Continuum. It's going to occur at 4 sites around the United States. It's coordinated by the American Association of Medical Colleges and funded by Josiah Macy Foundation. And what we have done so far is identify 4 medical students who will start, prior to starting their clinical rotations, whose clinical rotations are going to be focused around pediatrics. So instead of doing general surgery at Hennepin or the VA, they're going to do pediatric surgery. They're going to do pediatric ID. There'll be more pediatrics than internal medicine. It'll be focused here. But the other really interesting thing is these students will move forward based on the skills they acquire. So you don't have to wait 2 years to graduate from medical school after you start this. If you acquire the skills necessary in 16 months or 18 months, you move forward into the residency. And our residency has committed to these 4 individuals to have spots for them at the time they're ready to move forward. This is being looked at all around the country right now to see if this succeeds or not, because it allows learners to not just progress in a timeline, but really to progress as skills are acquired. And if it takes somebody longer to acquire those skills, they will have the opportunity to stay in place long enough to get those skills. Plugging topics and advances in pediatrics now. 2-day CME conference was coming up on June 4th and 5th. Last year we had a very good topics. John Abramson from Wake Forest gave the Wanamaker lecture and talked about influenza. Gene Abramson, the CM lecture, Des Runyon, the Thompson-Tobin lecture, Scott Crow on eating disorders, Practice Innovations panel. This will occur here on June 4th and 5th. Registration is free to employees of the department and residents. If you're one of the faculty, you have to use the form that John emailed you to get free registration. You can't go online. If you don't have the form, send John a note, send me a note, send Robin a note. We'll re-forward it to you. But look for an email from GOP chair or John Andrews? From John Andrews. That's where it is. You can send it around again. So it's free, but we need to have some understanding of how many people are going to show up, especially if we're going to feed you. So this year, the Wanamaker lecture is going to be given by Janet Gilsdorf from the University of Michigan, talking about preventing Neisseria meningitidis. Amy Gross from our department is going to talk about psychosocial implications for children and adolescents with obesity. Ann Garrity will give the Berg Lecture on Self-Compassion in Adolescence, and the Thompson-Tobin Lecture by Joseph Wright, who's the chair at Howard University, talking about bullying and its impact on children's health. So it should be a very good program. Our match is over. As a department, we did great. We filled our 23 peds positions and our 10 med peds position. As a medical school, we had our best ever. 98.7% of our 245 graduates matched. That's an incredibly good number. The other big news in residency and medical education was we had a 100% pass rate for first-time takers of the pediatric boards. This is the first time that's happened that anybody can remember. So everybody who's been involved in the education programs, congratulations, and congratulations especially to all of our graduates. Research mission. A big part of what we do is research. We come here, and a number of our faculty spend a lot of time doing research. We devote approximately 45 FTEs of faculty effort every year, 45 individuals' effort, solely to research. Now, it's divided up a little bit across people. Some people do more research time than others, but as a faculty of about 180 people, 45 of our FTEs are devoted to research. The vision for research is to have synergistic cross-divisional research that spans the continuum of the sciences and engages our entire faculty, includes very strong mentorship with really the goal to change the practice of medicine. One way of measuring that, and there are lots of ways of measuring it, is to look at how successful we are among our peers. Are we able to put forward the ideas that can be funded at the National Institutes of Health by the big granting organizations in the country? These are our sponsored direct costs on grants over the last 4 years, and you can see we've made some improvement. We're up to $21.6 million in sponsored direct costs. The next slide looks at data from what's called the Blue Ridge Institute. The Blue Ridge Institute is an organization that compiles this data from across the United States by departments, by individuals actually. You can go look yourself up and see how much money they say you have on this. This includes direct and indirect costs, but this is only NIH money. The previous slide included non-NIH money, but it includes direct costs, which here are about 52% of the direct costs. As you can see, we had a very big jump up in 2010 to 2011. This is called the CTSA grant. Now, it's not solely due to the CTSA grant, but our CTSA grant, our Clinical Translational Science Award, is held by Bruce Blazer, so it's credited to the Department of Pediatrics. But we actually have a whole lot going on beyond that. We've been in that $25 million range since that time. Our Blue Ridge ranking this year was number 8 of departments of pediatrics. A little disclaimer here, this is awarded to Department of Pediatrics, so places like Boston Children's Hospital or Cincinnati Children's Hospital, where the grants are actually awarded to the hospital, are not included here. So it's not, if you actually lined it all up, we're probably closer to 10 or 12, but still it's a very good group of people to be with, and here are our peers. The University of Minnesota is number 8 in this list, above Emory, above the University of Michigan, above Johns Hopkins, which I will point out to Dr. Jackson. But, pretty close to Pittsburgh, Stanford. Terry, you're not close to Denver. We'll work on it. But, it's really a strong group to be with. And again, this isn't prorated to size of department or anything, or research FTEs. This is just absolute dollars. These are the types of awards that have got us there. A number of investigator-initiated research, 18 R01s in the department this year, 3 R21s and 3 R03s, a number of individuals with their own K awards, 2 people with their own K08, K23s, and K05s. We're not including the K awards that come through the Clinical Translational Science Award. And then a number of training grants. We have 4 training grants, 1 in infectious disease, 1 in endocrinology, 1 in cancer epidemiology, and 1 in academic general pediatrics. These are really hard grants to get, and I really want to congratulate everyone, Mark Schleiss, Tony Moran, Julie Ross, Iris Borowski, for getting these grants. These are getting tougher and tougher to keep funded. We have won 2 program projects as well as 4 cooperative agreement grants as well with the NIH. The other metric that we are being asked to look at more and more are publications. Do we actually get our research out into the community so other people can benefit from it? In 2014, we had 346 manuscripts that members of the Department of Pediatrics were a part of. 169 of those were first or last author manuscripts. So it's a very good showing overall. The dean wants to see us do better on this, and I think over the coming years, there's going to be more emphasis on not just getting the work done, but getting the work published and out into the peer-reviewed world. Our clinical mission. So we talked a little bit about our daily safety calls, and what I just want to share with you is pretty straightforward. It's mostly just a series of slides that look at the volumes here and give you a sense of what our trajectory is on the clinical side. So our goal is really to have clinical practice programs that are local, national, and international destinations for complex care, exceeding the expectations of people, and really unifying our research and education missions at the bedside. The one area that we have dropped off in 2014 was our inpatient volume. We had a substantial drop in the last half of 2013 and early 2014, driven in large part by the absence of influenza. We had a very slow flu season last year. This is starting to pick up again towards the end of 2014. So our inpatient volumes were down and required some changes. We have had to reduce nursing in some of the units. We're building those up right now as volumes are improving again, but there's a ways to go. Bone marrow transplant continued to be strong. In 2014, we did 82 bone marrow transplant. We had done 85 in 2013. A place that has not had any slowdown is the emergency department. This is when we started. This is when we moved over here in 2011. We're doing about 1,500 visits a year. We are now tracking to do somewhere in the neighborhood of probably 15,000, 16,000 this year. We've had about a 10-fold growth in the emergency department, and it continues to grow. This is without any effort in advertising it or marketing it. We're actually starting to talk about whether we need to look at opening the sedation observation area in the evenings, really to create a secondary place to see some of these kids. We've hired actually three pediatricians now to serve as second attendings in the ED who can be there for the busier shifts. And we're continuing to look. If you have any friends that are board certified in emergency medicine that are looking to move to Minnesota for any reason, have them call. We are really struggling to find enough staffing for the emergency department. The other place that has been very busy is our clinics. It's hard to see here, but if you look down on the bottom, you can see that in 2013, we're about 55,000 visits in our outpatient clinics. We're up 3,000 more in 2014. We're up to 58,000. Our clinics have gotten very busy, not just here, but our offsite clinics are growing as well. I just reviewed the data from Maple Grove. I haven't seen Ridges in a while. The Maple Grove clinics are growing exponentially. So strong demand out there for endocrinology, cardiology, GI. We're limited in many of these by having enough physicians to actually do the work. So the last thing I wanted to comment on a little bit was it's our birthday. So in 1915, the Department of Pediatrics was founded. So this is Julius Sedgwick, and he was named the first chair. My understanding is that his work focused mostly around maternal child health, in particular breastfeeding. He was apparently a very early and a little bit out of sync proponent of breastfeeding in 1915. Over time, the department has grown and changed a lot. In 1975, John Kersey was one of the faculty who did the first successful bone marrow transplant for treating lymphoma. 1954, we have Walton Lillihigh and Richard Varco doing the first cross-circulatory procedure in a kid. Things continued to grow and develop. Somewhere in here, 1988, Dr. Warwick's development of the cystic fibrosis vest and his development of really a multidisciplinary approach to cystic fibrosis changed the nature of the care of those kids here and across the country. More recently, this is Cindy Howard and her kids. I don't know how she got in here, but Cindy's here as an example really of our first international global pediatric division in the country. Jacob Tolar's work around using bone marrow transplant to actually treat a disorder of a completely different organ, the skin. John Wagner's work using a genetically tested embryo for a suitable cord donor, and then more recently, the renaming of the Children's Hospital. So we've done a few things to acknowledge this, not a lot so far. We've added that cute little watermark. Faculty, you can download this. Use this on your letterhead, please. We are writing about this in department and University of Minnesota Foundation publications this year. But September 17th, we're going to have a celebration of this. And September 17th, there is a faculty meeting, so go for your calendar. You don't have to go to the faculty meeting that day. I know you were all planning on being there. But we are going to do a dinner for our alumni faculty and our current faculty. It will be held over at the McNamara Center. A number of things will happen, including the awarding of the Gold-Headed Cane Award. This is an annual award we give not just to former faculty, but really to an individual in Minnesota who has had significant impact in the lives of children. It's typically been a physician, but not always. There will be a dinner for all current and former faculty. And there will be some other things, other events that will be happening as well. There'll be some tours of the hospital that we may be enlisting people to help us with. We may have a mini symposium of sorts here for some of our former faculty to bring them up to date on some of the things going on. So more to come on this as the summer rolls out. So challenges. 2015 has brought with it its fair amount of challenges already, and I'm sure there are going to be more to come, but some of the big ones have been the formation of accountable care organizations. How do we really, as a tertiary quaternary care children's hospital, fit into this? We don't have a mass population that we're caring for. We're seeing lots of pressure on decreasing reimbursements. I don't think we're quite done with a proposed 17% decrease in Medicaid reimbursement. That'd be huge. Medicaid is a huge, huge source of funding for children's care. And we live in a very competitive market for our tertiary care. Children's Hospital of Minnesota is in the market. We're there. Mayo's not that far away. And Sanford in Sioux Falls has started to buy clinics and really become more active on the fringes of Minnesota, especially western Minnesota. And we're still dealing with very tight NIH pay lines. To be funded in 2015 typically requires scoring at the 10th percentile or less on your NIH grant. It used to be the 20th percentile or the 25th percentile. These things have gotten incredibly competitive and difficult to get, yet we are continuing to be successful. So how do we deal with these things? Well, one is realize that none of this is new. In the 90s, we went through the HMO sort of debacle here in the United States. And we went through this very aggressively in Minnesota. We had to get through those things. There's always been pressure to reduce our costs. And that just seems to continue, and every year it seems to intensify. There will be new challenges to fight as people try to push down costs. And one of the things that we are very worried that's coming our way is a push to reduce the amount of money spent on graduate medical education. Now, this is like the total disconnect of all time when we have the Institute of Medicine writing reports saying you need to increase the number of physicians going out into the workplace. Medical schools then go, yeah, great idea, we'll ramp up our classes. And then Congress says, guess what, we want to cut the amount of money for graduate medical education by somewhere around 20 or 50%. Actually, children's GME has been in particularly targeted, even by our current president, as something that they thought we could just drop. So we would have this, create this incredible funnel with all these graduates from medical school and fewer GME slots. We would be exporting our medical school graduates for their postgraduate training in that instance. If you see things from the American Board of Pediatrics, if you see things from the Minnesota AAP asking you to write congressmen, letting them know this is important, do it. They actually do listen to what you say. So please get involved in this. Those are going to be huge. Those would be huge game changers for us. So the other parts of solving this, we have an incredibly skilled and talented faculty. We have incredibly skilled and talented staff and residents as well. We need to really capitalize on those skills. We need to look for effective collaborations. There will be more pressure to reduce costs. We are continuing to look for ways not just to compete with Children's Hospital of Minnesota, but how are there rationally good ways we can form effective collaborations between us and there, between us and Hennepin? How can we actually create win-wins for everybody, especially the kids? And I think finally, remaining positive and proud. This is a strong faculty. It's one of the strongest in the country. And recognizing that we have the capacity to solve what we need to solve is huge in accomplishing it. So at the end of the day, we will come out and we will do well. I have absolutely no doubt that we will do well. So that's my presentation for this year. It's 5 minutes to 1, so happy to take any questions about anything. John.
Thanks, Joe. I wanted to make a comment and then I wanted to make a comment and then also ask you a quick question. Now, the comment is just to correct an error, and it was an oversight on my part because I know I saw these slides in advance of your talk.
Yes,
but in addition to the 69 residents in our categorical program in pediatrics, there are 40 residents training in the combined program in medicine and pediatrics, and that program is more representative of the coast, so it might have changed our map too had we thought to include them. But I wanted to acknowledge their contributions to the department. And then the question I had on the clinical slides, you showed clinical volumes, and then for the last couple of quarters, there was a red line that represented a target. I just wondered if you could say more about what generates the target and what that number means.
Yeah. So the target is essentially a number that we generate in discussion with the hospital every year that goes toward budgeting and staffing models. So I just pulled these slides directly off those reports. As we sit down, Fairview runs their hospital system on a calendar year basis. So as we sit down in typically September and try and anticipate what we believe the next year is going to look like, we set various targets that may vary by month. And then the hospital is out there really trying to make sure staffing is appropriate. In some instances, they do good. In some instances, we miss. I think everybody has been favorably surprised by the continued growth of ED, but it's really created a constant catch-up there. And I don't think we actually expected that there would be no flu season last year. And there was that, and then there was a pretty significant decrease in the number of bone marrow transplant admissions for about 6 months that led to some reductions in nursing staff. And actually about the time you did that, then bone marrow transplants picked up, and then flu season came back. Other questions? All right. Thank you all very much. Good afternoon.